Thank you for joining us and welcome to today's StarLIVE session. My name is Julian from Star Media Group and we're really excited to see everyone here today. Ladies and gentlemen, before we begin, allow me to share with you what StarLIVE is all about. As a way of connecting with you, our readers, Star Media Group presents an exciting array of talk sessions covering various matters of interest, from guides to leading a healthier lifestyle to meet and greet sessions with personalities. Our guest speakers for today's StarLIVE session are Dr. Tan Lee Peng and Dr. Tan Kia Lian. Today's session will be all about how you can prevent and manage diabetes, as well as how you can prepare for dialysis. Our guest speakers will be giving us insight on how to care for your kidneys and how having high blood sugar level can damage them. Ladies and gentlemen, at the end of the session, there will be a Q&A opportunity with our guest speakers. Before we begin, just a few housekeeping rules. Please switch your phones to silent modes and please reserve any questions that you might have for the Q&A session after the talk. And now, without further ado, let's welcome Dr. Tan Lee Peng as he highlights how raised glucose can hurt the kidney, as well as bring us through ways and means to help our bodies restore itself to optimal health. Dr. Tan?
Good morning. Thank you all for coming. So, I plan to spend the next half an hour, 40 minutes or so, to illuminate a little bit about what diabetes and what the kidney is about. But before I begin, I'm going to show you this picture. So this is my grandpa. He passed away when he was 104. Wow, yeah, 104. And you know what he passed away from? He passed away from old age. He had colon cancer. He had colon cancer at the age of 100 years old. And at 100 years old, he got an operation and survived the operation, did quite well, was mobile, walked 10,000 steps a day up until the day he passed. 104, right? This is my other grandpa. Oops. This is not working. Oh, here we are. It's my other grandpa. There he is. So he passed away when my father was 10 years old, right? So they look the same. But what happened to him? He passed away because of diabetes and high blood pressure. That's pretty amazing, right? So someone who is born in about the same era, something changes about them. Their genetics change, right? You don't know what kind of genetic you are, and how long you're allowed to live. But the presence of diabetes apparently took away 30, 40 years of my grandpa's life. So instead of living to 104, he only lived to about 60 years old, so on. So wouldn't you love to live to 104? How many want to live to 104? Not a lot of you. Surprising. Surprising, I do. I want to see what happens when I'm 104, right? So we all want to. So what can we prevent, right? We can't prevent genetics. Genetics is something we can't prevent. But what we can prevent is we can prevent the likelihood of us getting diabetes. So this is what I want to do with us today, okay? So we're going to go through a little bit. It won't be very detailed. It won't be very serious because this kind of a talk, we can't give too much detailed information. But what we tend to do is we tend to talk about principles. We're going to talk about how sugar can affect us and how it can affect our kidneys, okay? So that's what we're going to do, all right? So if you have questions, hold them to the end. Hopefully we'll be able to cover some of them during the slides we have today. But otherwise, hang on there. So one of the first things that I want to ask you is, what did you eat just now? Did you get this? How many of you saw that and went immediately and put it in your mouth? Yeah, and a lot of us are. I took it and I kept it specifically because I wanted to show you. So one of the important things about understanding how we're going to prevent diabetes is this. So the first thing we have to do is we have to be mindful about what we're going to eat, okay? What we're going to put in our mouths. So the first thing we can do to prevent the likelihood of getting diabetes is to say, hey, stop. Think, okay? And then go, all right? So stop, look, go. Very simple thing for traffic rules. So stop, look, betul ke? You really want to put this in your mouth ke? Okay? So then go, okay? If yes, then take it in, all right? So mindfulness in everything, all right, should be practiced. So that includes eating, that includes living, that includes everything that you can think of, right? So the first thing about preventing diabetes is to say, hey, let's pay attention. Let's stop a while. And let's think about what we're going to put into our mouths today. Okay? So what is diabetes exactly? There's a lot of people who aren't really sure yet. So I'm going to tell you it's an interplay between this organ, which is the pancreas. All right? The pancreas is right here. So if you put your hand right around your middle area, that's the head of your pancreas. And then it goes towards your left side. So that's your tail of your pancreas. And you know which famous personality died from pancreatic cancer? Steve Jobs, that's right. So it's right around here, it goes around to the left side, okay? And it's an interplay between this and this, the gut, okay, the stomach. So the stomach and the pancreas have a very close relationship, right? So diabetes is actually an abnormality between the two. They two don't communicate, right? They don't communicate, and they produce the bad problems that we have today, okay? So it gives us this as well. So this is also a problem. How many of you have this? I have a little bit of it. How many of you can grab a lot of it? I grab a lot of it. Do you want to get rid of it? Yeah, it shouldn't be there, okay? We don't need it anymore. When we are about, prehistoric times, this is good. It helps to prevent us from starvation. Now we have seat belts. We have airbags. We don't need this anymore, okay? So, this and diabetes and gut all come together, and they are all mismatched together into giving us the kind of disease that we know as diabetes. So where's Malaysia? Look at that. Look at our neighbors, right? So our neighbor Singapore is not far behind, okay? So Thailand is 30. We are 44% overweight. My goodness. And why do you think that is? Huh? Too much what? Mamak shop. Okay, I mean, no restaurant providers are here. So it is because we love to eat. Okay, we love to eat, and we can't envision lives without eating. We see people, we say, hey, how's your, makan sudah makan, eh? So we see people, we say, hey, have you eaten yet, right? Number one. Number two, we love our car. Don't we? We love our car. We love our transport, right? We can't imagine walking 10 minutes. No. It's too far away. It's too hot, okay? And then I always see that in our hospital. Our hospital is very small, We have a nice, lovely, boutique kind of hospital. We only have 4 or 5 floors. And most of the wards are on first, second, third floor. And every time we see, very easily, people come in, first floor to second floor, ding. Go up, elevator, 1 floor, ding, second floor to third floor. So we don't like to move, we don't like to walk. And that probably contributes to why, we have a 44% overweight rate. And guess which state of Malaysia is the most obese? No. Putrajaya. Guess where the second state is? Malacca. Someone shouted out Malacca. Okay? So Malacca is the second most obese state. And why? Lovely Nyonya food. Okay? Fantastic Nyonya food. Everyone loves to eat that. So we don't want to do this. Okay? We don't want to do this. This is what contributes to our diabetes, our obesity. And I'm going to show you approximately what happens when all this good food goes into our system. Okay? So food comes into our stomach and it gets broken down. Right? It gets broken down. And it's broken down into many, many things. But when it gets broken down, the whole purpose of this is that this food is going to get absorbed into our system. Right? So the food goes into our gut and it sends signals, and the pancreas starts to produce this lovely hormone we know as insulin. Okay? Because you want to have the energy from your food come into our system to allow us to do the things that we can do today. Okay? So all that stuff is broken down. It goes to our stomach, our intestines, and our intestines have these specialized cells. So these cells are there to absorb all these ingredients, right? All these ingredients are supposed to be absorbed, and then it's going to be delivered into our body so that it gives us the energy that we need. And we need energy to survive, okay? So we need this energy to survive, and then after that, all these things are broken down and are absorbed into our system, okay? So all these lovely little dots, etc. All right? So what does insulin do? Insulin comes, it says, hey, I've got this sugar in my blood. All right? I'm going to take this sugar in my blood and I'm going to put it into the cells that needs it. Yeah? It's going to put it into the cells that it needs it. So what is diabetes? Diabetes is when insulin cannot or too difficult to put sugar from the blood into the cells. And that's all that it is. Okay? So diabetes is just too much sugar floating in the bloodstream because the insulin, the carrier, the important thing that your body produces, cannot put that sugar from the blood and carry it into the tissues where it needs to be. So why is that? Why does that happen? Okay, then you have this particular problem where there's too much sugar in the blood, and that sugar goes everywhere in the body. Okay, it goes everywhere in the body, and it causes all kinds of problems. It causes heart problems, kidney problems, eye problems, nerve problems, blood vessel problems, which we have a blood vessel expert with us here today. So blood vessel problems can also result from diabetes. So it can hurt everywhere because blood and sugar go everywhere throughout the body. You know, every patient says, you know, if I have diabetes, I'm worried about what? I'm worried about kidney. I'm worried about nerves, correct? Okay? But little do they know that because blood flows everywhere, actually every part of the body can be injured. You just don't know it. Okay? People often forget the eyes. The eyes have blood, and that's where the sugar goes, and that's where it's injured as well. So it can really affect everywhere. So what happens to this sugar? So, and why is it closely related to fat? Okay, it's because all that sugar that is extra, that is floating around in your bloodstream, that the insulin cannot deal with, what happens to it? The body says, oh my gosh, I've got all this sugar, okay? So I've got to do something with it. So I'm going to store that sugar as fat. I'm going to store that sugar as fat. And the more fat I store, the more difficult it gets for my body to get rid of that excess sugar. Why? Because fat coats all of our cells. And then insulin, when it comes along and it tries to put that sugar into the cell, they cannot. Because fat is there as a barrier, as a halangan, okay? Fat is there to say, cannot, I don't want to accept the sugar, so insulin has to increase more and more and more and more, and then we have this problem we know of as diabetes, okay? So we carry fat around with us like a camel, okay? Because fat is our storage. So when we eat too much, our sugars are there, the sugars get converted into fat, and then it gets stored in the body, and this is an example of where the fat is stored. Now, where is the fat stored? Can anyone see? And so all this white color stuff is fat. So where do we not want to have it stored? We don't want to have it stored around our heart. We don't want to have it stored around our liver. We don't want to have it stored around our intestines. And that's exactly what's happening. See, all that fat, all stored around our heart, all stored around our liver, all stored around our intestines, and that's partially why we get the problems that we get today. Okay? So fat, diabetes, obesity, all linked. All linked. Okay? All linked. Right? So what should we eat? So before we talk about that, I just want to make a little bit of a point here. I've got a... So we talked just now about sugar, right? Okay? So how much sugar do you think is floating around in the blood? How much sugar? Anyone guess this much sugar? No? Let me just tell you how much blood you have in your body, yeah? How many of you are 70 kilograms? 70 kilograms. Okay. So how much blood do you think you have in your body? Something, enough. This is how much blood you have in your body. Okay? So what is the calculation? About 0.6 of your, 60% of your body weight is blood. Okay? So this is the amount of blood you have in your body. Okay? And how much sugar do you think all this stuff contains? This much. Huh? So this teaspoon of sugar is the amount of sugar that is diluted in your blood. So that's all. Okay? That's the extent of control that your body is applying to sugar. Okay? Too much, tak boleh. Too little, tak boleh. So how much is just nice is just 1 teaspoon of sugar. That's it in that. Okay? So that's the amount of sugar you have diluted in your blood. So you can understand that you eat a lot, right? How much of this thing is in 1 can of Coca-Cola? A lot. Okay? So you can imagine if you drink more and more a day, right? What happens to all these things? So it gets diluted to this, and this goes everywhere, by the way, everywhere. And then we get into problems, right? So I'm just going to go through very simple things. So carbohydrates versus proteins versus vegetables. So carbohydrate is sugar, but not all carbohydrate is bad. You need to have complex carbohydrate because that's what your body needs, right? And is less able to use the sugar. We want to give you this idea, and we're going to speed through this, and we can ask stop time for questions later, that there's certain things which are easily broken down by the body and certain things which are not so easily broken down by the body. So carbohydrates have a index score to them. So what you want is you to eat your foods or your carbohydrates from something with a low index score. Because what that means is that the sugar that is coming from your food is very slowly digestible by your body. So it doesn't give you the spike in sugar that happens, okay? So what is that? So those are things like basmati, vegetables, lentils, pasta, whole grain bread, oats, etc. So what we like to eat potatoes, ice cream, biscuit, chips, cakes, watermelon, etc. Okay? So all that stuff is sugar coming straight into our bloodstream. All this stuff is sugar that's coming slow into our bloodstream. Okay? So how slow? You see the green line here, and as opposed to the white, yellow line here. So sugar from the green line stuff takes a long time to process. So we want that. We don't want the sugar to immediately be absorbed. We want the body to take its time. So we want sugars to come in at a very slow rate into the body, yeah? At a very slow rate into the body. So eat some things with caution. So what are they? So these are the examples of scores that you can look online. Okay? And what you want is you want a lower score. Okay? You want a lower score. Look at the banana is 56, whereas dates are 103. Okay? So Ramadan is happening soon, and lots of people book out with dates. Okay? So dates are 103 in red, and bananas are 56, kiwis are 52. Okay? So what does that mean? That tells you how easy it is that the body breaks down this food and lets the sugar come into our body and then gives us a problem. All right? So be mindful of what stop, look, go, okay, about what food you're putting into your mouth. Understand what that food is doing in your body as your body deals with this food, and you are deciding whether or not to put this stuff in your mouth. Okay? Healthy plate looks like this. I grew up not like this. I grew up healthy plate looks like more of that, and a little bit of that, and none of this. Okay? So a lot of us like to eat like that, right? So you go for, very easy, I give you an example. You go for your bihun in the morning. It's all bihun, a little bit of egg, and no vegetable. Okay? So change the way we eat. More fibers, more vegetables are more important. Okay, so just some tips on blood sugar, yeah? So I'm going to go into a little bit of how sugar affects the kidney. But let me just bring you along with this. So these are the numbers that I want you to remember. So now it's very easy to measure your own blood sugar these days. You can go to any pharmacy, you can buy a little sugar monitor, and then you can check. And this checking actually is very straightforward. It doesn't hurt much. Doesn't hurt much. And one day, Malaysia will have the ability to have a patch. And this patch, you put it on your skin, you can use a scanner, scan, and it can tell you your blood sugar. It's already in Singapore, already in Hong Kong, and it will come to Malaysia soon. So that's the new style of technology that we have available for us to check blood sugar. So what blood sugar do I want you to remember? 711. Okay, 711. Very simple to remember. So 7 is, it shouldn't exceed 7 if you're fasting, and it shouldn't exceed 11 if you've already makan. Okay, so at any one time, you can remember this number, 711. Okay, if I've eaten, shouldn't be more than 11. If I haven't eaten, shouldn't be more than 7. Simple. Okay, simple. The second measure that you want is you want to measure 3-month report card. So we all have a report card for our sugar. So this 3-month report card comes in a percentage, okay? And this percentage is how much percent of sugar is on your blood at any one time, right? So it should be less than 6.5%, shouldn't be more. If it's more than 6.5%, we have a problem, right? We have a problem. So you want to check these 3 things, 7-Eleven, and then you want your 3-month report card, the HbA1c. So nowadays with diabetes, we have a lot of new drugs. So no doubt some of you have read recently, a lot of new drugs are coming out and they're saying, wow, some of it can reverse diabetes. Some of it can protect us from having heart attacks. Some of it can extend our lives. So don't be afraid of diabetes if you do have it, right? Because the way we are managing diabetes today is very different from the way we managed diabetes 10 and 20 years ago. Because now there's more and more new things available that can not only restore, hopefully, diabetes if you do have it, but also protect you from further damage. So that's very important. Okay, so for the next 15 minutes, we're going to think about the kidneys, right? We're going to think about the kidneys. And I'm going to tell you a few things I want you to remember about kidney details that you can take home. And what to look for in your kidney blood test, okay? What to look for in your kidney blood test. So we don't want this to happen to anyone. So I trained in the US, and in the States, there's a lot of kidney failure as well. The difference between the States and here is that it's relatively easy to get a kidney transplant. So, anyone can donate kidneys to anyone else. So oftentimes when we practice, we have people coming into our clinic saying, hey, I have 2 kidneys. I want to donate one of my kidneys to someone who needs it, Okay? So we can't do that here. So because we can't do that here, we therefore have not a lot of kidney transplants. So because we don't have a lot of kidney transplants, we have a lot of people on dialysis on kidney failure. And that is a problem. And we want to reduce that, okay? So we don't want to get into these scenarios where we have kidney failure. So let me tell you a few things that hopefully will give you some ideas. This is not this actual patient, it's just a snapshot, but the name also made up, but is a real patient. So patient comes to clinic and says, hey, doctor, I'm a bit nauseous recently. My legs are a bit swollen. I've got a bit of an itch. And I've lost my appetite. Things don't taste as good as they used to. Things don't taste as good as they used to. So we do a couple of tests. So we are testing for these 3 things. So these 3 things are the bare minimum that you need to do every year in order to make sure that you have a normal, healthy kidneys, okay? So in a blood test, this is what you want to look out for, okay? You want to look out for this number called the creatinine. So this number, creatinine, with this number GFR, tells you the kidney function of your that you have at this present time. And it comes usually in a 2-digit number if it's normal, and a 3-digit number if it's abnormal. Okay? So this is how you look at your blood test. You look at the side here, creatinine. You look to the right side, and that's your number. And you look to the extreme right side, and there'll be a normal reference range. So the range is the lab that tells you that for all their patients, 90% of them, their numbers are like this if it's normal. So you look at your number, and you say, this is good or no good. This person is no good. Okay? So the lab will tell you if it's no good because usually they will bold it. They will color it red, or they'll give you a number at the side there, a letter. So this letter, CH, stands for critically high. Some labs give you H high, some labs give you whatever thing they have now, right? But this is the thing you want to know. The second one down, the EGFR, is actually kidney function, all right? So the function, the higher the better. The creatinine, the number, the lower the better, okay? So creatinine number, the lower the better. GFR, which is the function, should be the higher the better. So how much should it be? It should be at least more than 60, okay? So this person's number is equivalent to a function of 5. That's bad, okay? That's bad. That's very low, all right? So what else do we look for? We look and see all these things that are abnormal when the kidney is abnormal. So when the kidney is abnormal, our lab does something called carbon dioxide, all right? So carbon dioxide is a measure of how much acid you have in your body. So one of the things that the kidney does is that it gets rid of acid, okay? It gets rid of acid. So if the kidney doesn't work, acid starts to build up. And when acid starts to build up, this number goes down. Carbon dioxide goes down. If it goes down too low, people can collapse. Okay? People can collapse. You can have a heart attack. The other number we look for is potassium. So potassium is so important in our body because it affects our heart, right? So if the kidney doesn't work, potassium goes up. And when potassium goes up, you are in trouble. The heart can stop. Okay, the heart can stop. So these are the things I want you to look for in your blood test. So what else do we need to do? We need to do a urine test. Okay? So the very bare basics about kidney function is you want to do a blood test and a urine test, and this is what you look for. You look for something called a urine protein. Okay? So the urine protein will give you a number, and if that number exceeds the range, you get in trouble. Right? That means your kidney filter is being damaged, and protein is leaking from your blood into your urine, and then your kidney structure is being impacted. And how can you tell at home? So at home, you have a urine dipstick. You can buy this in the pharmacy. You can just dip it in your own urine and see. So what you want to look for is you want to look for the protein on color coding, right? So if you have a protein color coded as abnormal, and here this test gives you 4+, that tells you that you may have a problem, that your kidney is leaking protein, right? And then you may want to go and see a doctor and get it checked out to see why is it leaking. Because some people have got simple problems that can be fixed, and some people it may mean nothing, and some people it may mean very bad things. All right? Okay. So in some people, we also look for this. We want to see whether or not the urine test has got something special. We know as casts. So if there's a cast that we see, usually that implies that something has damaged the kidney. So the cells within the kidney have been torn out, and then they get stuck inside the kidney, and then they form a cast. You know what's a cast? When you break your arm, you put your arm into a cast. That's exactly what they see in the urine. They see the urine cells have formed a cast, okay? And if they form a cast, means that they have been damaged, and then they are floating through the urine and then get stuck. And then they get stuck inside the kidney tube, and then they form one block known as a cast. And we see that, we say something's wrong with your kidney. Okay? It's not just diabetes, it's something else. Right? Something else. So these are the things that we look for when we look at the urine test. Okay? We do a kidney ultrasound. So what are we looking for in the ultrasound? So in the ultrasound, if any of you have seen this before, this is what it looks like. It's not a very nice, very clear picture, but it's easy to do and it's cheap, right? So the kidney looks like this, and inside there are black spaces, and those black spaces are where urine accumulates in the body. So sometimes we see that there's too much black space, and this is called swelling of the kidney. Sometimes you go to see your doctor, and your doctor says, oh, your kidney is swollen. So what do they mean? They don't mean that the whole kidney is swollen, okay? What they mean is the space inside the kidney, right, is too big. It's too big. And this, why does this look like that? Because somewhere down the line, urine is being blocked and cannot come out. And when urine cannot come out, it gets backflow, and you have this enlargement within the kidney of the space. Right? And one of the very common cause is kidney stone, and for men is prostate. Right? So this is what we look for. We look for cysts, balls. balls of fluid in the kidney. Okay? So these cysts can sometimes be found in our kidneys. And what we want to see is want to make sure they are not cancerous. Okay? They are not cancerous. Right? So these are the ways in which we measure kidney health. Kidney health. All right? Lastly, we look for stones. So you can see on the ultrasound scan that these are stones of the kidney. And then if we want to look at them more clearer, we do a CT scan. And then we do a CT scan. We can see the stone here. We can see the stone here. Okay? So these are the ways in which we look for kidney function and kidney testing. All right? So I'm going to flip through this as I'm going to show you what exactly diabetes does to your kidneys. So this is a main functioning unit of your kidney. It's called a nephron. You have 2 million of them. Right? You have 2 million of them. Each nephron is 0.9 centimeters. So if you stretch them out, they measure 19 kilometers. So you have 19 kilometers of filter in your body. That's amazing, right? That's amazing. So it really takes a lot to destroy them, okay? So this is the kidney. You have 2 million nephrons, all right? And we filter all of that in our blood every hour, okay? So every hour it's being filtered in our blood. Now I'm going to show you how exactly diabetes affects the kidneys, okay?
The development of diabetic nephropathy involves hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria.
So you can see all this blood going
Increased
through the
afferent
kidney.
arterial dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure,
So
which
you
is
see all the
associated
pressure
with greater
increasing within
mesangial
the
cell
kidney.
matrix production. Expansion of the mesangial area and early morphological
So all this
change
stuff
with
is happening
diabetic
inside
nephropathy is
your kidney at
caused
any
by
one
greater
time.
extracellular matrix deposition
See all this
and
blood sugar?
mesangial cell hypertrophy. This expansion is associated with a decreased
And then they
glomerular
change the kidney.
filtration rate
So you can
and a
imagine
reduction in the surface
that all this
area for
sugar is
filtration,
being
which
present in your
marks the
blood, and as it
beginning of
filters
renal
through,
failure.
your kidney cells are
As
being
this
damaged
process
bit by bit,
continues,
bit
the
by bit,
glomerular
bit by bit.
basement
And that's
membrane
what's happening
thickens, and this
if you
may
have
eventually
diabetes
lead to
and if you have kidney
glomerular
disease.
sclerosis.
So this is what's happening inside your
All of
kidney.
these changes
It's
in
changing from a
glomerular
beautiful
hemodynamics
looking
cause
picture
stress
to
and
something
strain
that's
on the
scarred down,
kidneys, which, if left
looking
untreated,
like this.
may result in renal failure.
Okay? So this is what we want to prevent. So very simple rules before I end off, okay? Very simple rules, and then we can hold some questions for later. So the first thing is that we have to control the pressure within the kidneys. So you saw just now that there's a lot of pressure going through the kidneys. In fact, we filter the whole 5 liters of blood from our kidneys at any one time. So we have to control our blood pressure because that's the amount of pressure that's going that you are seeing in your body system today. So I want all of you to buy a blood pressure monitor and use it. So nowadays, it's very easy to get blood pressure monitoring. You buy it, you keep it at home, you use it, you do it twice a day, and you need to get your blood pressure less than 140/90. Okay? I want you to exercise because that's how we burn calories, and we need to maintain a healthy weight, and we don't want to do this. Okay? We don't want to do this, we don't want to do that. That's Asian. Yeah? It's the same as that. Okay? So we don't want to do all these things. Rule number 3, be careful what you put in your body. Be careful. Now, a lot of us are very sensitive towards Western medication, yeah? So a lot of people come and say, hey, you know, doc, this medication can hurt my kidneys, can hurt my liver. But then we don't pay any attention at all to herbal supplements or supplements that we put in our body. So do the same kind of careful monitoring of herbs that you do with Western medication, okay? So make sure that they have logos, all right? Make sure that they are certified, they are coming from the proper place, and make sure your blood pressure is normal. So lastly, I'm just going to skip through some of these things. right? And we can save it all for later. Cholesterol. Cholesterol is one of those things that starts to block up our blood vessels. So if we start to allow cholesterol to build up in our blood vessels, we get into trouble, right? So make sure that these very simple, very basic things are dealt with, and then we can have a normal kidney function. Lastly, drink enough water. This is Malaysia, right? We need to drink water. We need to get well hydrated because that's the only way we maintain circulation in our kidneys, right? So thank you very much. I've shared a little bit about how diabetes affects our body, how it develops. I've shared with you a little bit about how your kidneys are affected and how you can monitor your own kidneys in a way. I've not gone very deep into detail because we will save those for our Q&A session later for those of you who have specific questions about how these two things interact. But before that, I'll pass over to my friend Julian, okay, to introduce friend and colleague Dr. Tan Kia Lin.
Thank you very much, Dr. Tan. Ladies and gentlemen, for the next session, join me in welcoming Dr. Tan Kia Lin up on stage to talk about renal replacement therapy and elaborate the options for treatment.
After listening to a nice talk from Dr. Tan Lee Peng, just a while, we're going to continue. So we're going to start from where he ends. The same slide that Dr. Tan Lee Peng ends. I start here. Okay, let me introduce myself first. I'm Dr. Tan Kia Lin, actually the spelling actually more on Malay side. I'm a vascular surgeon. I think maybe a lot of you never heard about vascular surgeon in Malaysia because there's very few of us. There are less than 30 in Malaysia for a population of 26 or 27 million. If you compare to Australia and New Zealand, add up together the population, almost same like us, there are more than 400 vascular surgeons. Vascular disease are more covered and well attended to in a developed country compared to ours. Why it happened like that, actually, that's not for me to comment. It's a policymaker's problem, not ours. The reason that I'm talking about this is this very important. In case you don't get anything from this session, wasted a few hours. One important thing that you must take home is that see a correct doctor for correct things. You don't see a doctor for things that doctor doesn't know how to manage you. Do you know who Dr. Tan Lee Peng is? What he specialized in? You know that he's a physician, of course. You know that he's a nephrologist. Do you know that? Do you know that what does a nephrologist do? Looking after kidney diseases. So if you have problem with kidney disease, go to a doctor who look after kidneys. Past few days, I've actually run clinic. My clinic like very heavy. Sometimes I get quite annoyed when patient come to me. I have kidney disease. I saw a doctor which doesn't know about kidney, and doctor advised him on the wrong direction. That's quite annoying actually to the, that's why I come to this idea that first thing, you get to the correct doctor first. You have a diabetic problem, you look for endocrinologist. You have a kidney disease, you look for a kidney doctor. So don't go for the wrong one and get the wrong consultation and wrong advice and going all the way to Malaysia. We were saying it, but we stopped there. I'm a vascular surgeon. Actually, I'm dealing a lot with blood vessel diseases. We've thought about what is vascular surgeon. I deal with all the blood vessel outside the heart and the brain. Most of the blood vessel, the aorta, the artery, vein, and things that I manage it. So diabetic microangiopathy and macroangiopathy is part of my field. But I'm not going to talk about that today. Because of here I'm trying to create another awareness. When you come to a stage that your kidney disease is almost like, no hope, no chance after all your, treatment or whatever attention you pay into. You come to a stage that you need a renal replacement therapy. You have to attend to it. You can't avoid. Why I say that? Because nowadays we see a lot of patients trying to avoid that and harm themselves in a very bad stage. You can ask Dr. Tan Lee Peng. I saw him always sitting in the ICU, manage with patient towards the end stage. They know that earlier. They're trying to avoid it. They don't want to prepare themselves. Come to a stage that they are unconscious. They are very danger, not only affecting the renal. They become unconscious because you remake encephalopathy, the heart function fail, multi-organ failure. Then come to us. Please salvage us. You can avoid that. You don't need to go to that stage. And why our public have very poor awareness about that? That's because of the medical information, which is not enough channel to our public. I hope that after this, you can, even though to your friends, tell them something that if you have a renal impairment, don't get too worried. First, you can look for Dr. Tan Lee Peng or nephrologist. Ask them the method to delay or prevent it from further damage first. But when you come to a stage that you need it. You can't run away. One thing that in Malaysia that I found, I think out of the population, when you have hypertension, your friend will tell you, don't take the medication. Why? Because after you take the medication, you have hypertension. That's very funny, right? Very funny, but it's real, it's true, it's happening around us. In Chinese, we're saying that the ostrich is hiding the head to avoid the things. That's a true thing. Don't do that, okay? You'll further harm yourself. Don't try to avoid, don't try to deny. You can look for second opinion, third opinion, whatever, to clear your doubt, make sure that the diagnosis from one single doctor is correct. And then you prepare to face it. So what about renal replacement therapy? Are they so scary that all the patients trying to run away? Conventionally, there are three types: renal transplant or kidney transplant, peritoneal dialysis, and hemodialysis. And because in Malaysia, most of us are actually dealing with hemodialysis, I'm going to deliberate a bit more on that. How about kidney transplant in Malaysia? Almost close to hopeless. This is from a National Resource Transplant Centre from the government agency. 25,000 patients awaiting renal transplant. Only 1% of general population pledged to become an organ donor. And then we have only 30 to 40 cases going on a year. And how many failure after this, we still don't know. So if you want to wait for that in Malaysia, the hope is very, very little. And then, unless some of your relatives willing to donate to you, you can go on for living-related renal transplant. If you're waiting for cadaveric, waiting for somebody, after trauma, about to die, but they're healthy, the kidney is healthy, and trying to get their kidney, the chance is very, very minimum. So, of course, we all know that some of you may, I have money, I go somewhere, get the kidney and come back. Well, if you can do that, you can do that. That's the best method of renal replacement therapy. But the chances in Malaysia is very, very minimum. How about peritoneal dialysis? Why are we not doing that a lot in Malaysia? That's, I think, also policy related, not for me to discuss. We have less than 10% of population actually, can't go back. We have less than 10% of population actually on peritoneal dialysis. That's a figure released by our Ministry of Health, but I believe figure it's much less than that. Maybe 1 or 2% on peritoneal dialysis. Actually not that scary, They actually got scared by doctors that this peritoneal dialysis is, you can't do that because of this and this factor. So there are two types of them. One is a continuous ambulatory peritoneal dialysis. In short form, we call it CAPD. Or the other one, automated peritoneal dialysis. The difference between one is going on the whole day for CAPD. Automated is you need a machine. You do it at night for a few hours, and then the life goes on. It's actually much simpler to manage. What you need to do is actually a silicone catheter in your tummy that put in your abdominal cavity, drain the fluid in and out, and that help you to manage your renal failure. What's a pro? The advantage side of peritoneal dialysis, you don't need a needle, no need to be pricked. Every time you go for dialysis, it's quite flexible schedule. You can do it at home, in the office, anywhere that you want to do it. You have fewer fluid and diet restriction, and better blood pressure control also. So the con side, the not so advantage side is, a lot of people don't like a catheter stick out from the tummy, and need to take care of it, prevent it from infecting. And then your tummy always filled with fluid, because the water in the tummy actually help to clean up the toxin, drain the excess fluid. So you feel uncomfortable with the tummy. Otherwise, it's quite a good option. But unluckily, we have very, very few patients doing that. Even though they're running out of access for hemodialysis or the dialysis using your blood, they dyingly don't want to go into this. So we still have a big population that have potential to go into this if all your access fail. Hemodialysis, this is most common in Malaysia. Nowadays we have a population about 40,000 of renal failure patient on dialysis. Compared to the figure 10 years back, was like 26,000. It came up quite fast. The new incidence 10 years back was about 4,000 kidney failure patients a year. But now we are approaching 7,000 to 8,000 a year. So we are looking at 2030, we have 100,000 population on dialysis in Malaysia. So it's quite huge problem to tackle, and a big problem. And what does we do in hemodialysis? Actually just, send the blood, your blood, instead of sending to kidney like the picture, the picture that Dr. Tan showed, the blood flow to kidney, filter, come out, go back to your body. But this is external. We have artificial kidney. Here, blood going here, filter through this artificial kidney, go back to your body. That's how it does. The advantage side is actually, it's quite suitable for population like us, which we don't want to care about anything. We pass everything to others. We have dialysis, I don't want to know much about it. I go to center, I sit down there, the nurse help me take care of it. I just go back home with 2 plasters. That's generally what happened in Malaysia. They don't want to know much. They just want to get the things done. So it's a center-based. In Malaysia, I think because of the policy and some, quite difficult on men, I don't want to touch on that. It's widely available. You want hemodialysis, you can get it everywhere, each and every state. And they are carried out by trained nurses, quite safe. And during dialysis, you actually have contact and can talk to your friends and contact with the other patient who have a similar disease and can discuss on how they manage a problem. The con side is always, we need vascular access. You need somewhere for the blood to drain out from your body and go back to your body. So that's a problem in Malaysia. Like I told you, we have only less than 30. And modern vascular surgeons like us who are doing surgery and endovascular treatment are not more than 5. So that's a difficulty to get a proper vascular access. I'll talk to you about the access afterward. That's very important, how you prepare your access and go for dialysis. And during each dialysis, you need 2 needles stick in. 1 outflow going to the machine, 1 backflow going back to your body. So your filter blood, the clean blood, go back to your body after that. And you need to restrict your water and diet, because in here, unlike some countries that you do it daily, here we do it 3 times a week, 4 hours a session. So during that 2 days that you don't have your dialysis, or especially during weekend, instead of 2 days, become 3 days. You need to restrict your water intake more. Otherwise, when you come back for dialysis, you extract more and then make your dialysis more suffering. Because Dr. Tan, I borrow yours. This much of 5 liters of fluid in your body, 70 kilo men. Imagine that they have to pull out 3 liters from that during dialysis. How much blood left in your body? 2 liters. Is that 2 liters enough to maintain your circulation, provide sufficient blood supply to your brain and to your heart? Obviously, we know the answer is no. And we suffer from that. So you have to do a good fluid and diet control if you're on hemodialysis to avoid all these problems, and not blaming on the machine, not blaming on the nurses, and not blaming on the doctors. Because you are the one responsible for your own fluid intake. Nobody force you. And then, of course, like what I said, 3 times a week, 4 hours each session you have to spend in the dialysis center. So there's a disadvantage side of it. So this is the most common. And for hemodialysis, you all know we need assess. How to assess? What are the type of assess that we have? A few common misunderstandings that I need to clear before I go on. Because of these are the questions actually thrown to me each and every time patient come to me asking for a vascular assess. They have an idea that if I create the assess or the place that they're going to do hemodialysis, their kidney function going to deteriorate further. And for sure they're going for dialysis. This is something wrong. The fistula or whatever the assess they put in doesn't affect your kidney function. It just changes your circulation. It just changes your hemodynamic pattern. Especially if you put in the hand, only the circulation in the hand will change. So it doesn't deteriorate your kidney function further. You need dialysis after the assess put in because your kidney function is on the way down. It's just a matter of time that you need this. So you better get yourself prepared before you come to that stage. And the other misunderstanding is a lot of people think that, never mind, I wait. I do it when I need it. But assess is something not like, I do it today, I get it tomorrow, I use it tomorrow. No, never like that. Not only in Malaysia, worldwide it's like that. You go to US, you go to Australia, you go to New Zealand, situation is the same. You create the fistula or create assess, you need to wait for at least 6 to 8 weeks if a good surgeon did it for you. If you do somebody that's not very familiar, sometimes you have to wait even up to 3 to 5 months before your fistula can be function. So don't wait for too long. When you're diagnosed with it, you need it, quickly get it done. Otherwise, you suffer like what I said just now. ICU stay, all the invasive needle pricking into your body and try to help you recover from that. One more, the other things that most of patients ask is, can I use my hand after the assess creation? Of course you can. You do it properly, your fistula is good, you just wait for recovery time, the anastomosis heal, the skin wound heal, you can go for any exercises. I have no restriction. I have patients after the fistula creation still go on golf, go on the activity. I have a hawker still, every night. They need to earn their life. Otherwise, how are they going to support their dialysis? So these are the things which is, the wrong misconception that, once I have my fistula, I should be on a wheelchair. I cannot move my hand. I wait for everybody to do everything for me. That's wrong. Definitely wrong. Why we put you on dialysis? Why we put you on renal replacement therapy? Because we want you to go back to community. You should function back as normal. Not thinking like, I'm on dialysis, I'm sick, I'm ill, I'm waiting for the end of my life. That's wrong. Then if you think of that, you don't need replacement therapy. And one more is that, once you create a fistula, especially, patient asks, doctor, you put the pump into my hand. You put the motor into my hand. No. Create the assess is actually very simple vascular surgery. You don't put anything into your hand. You don't put anything. The things that you put into your body is one very thin string of suture, just joining the vein to the artery. And we get the flow from high pressure to low pressure area. You got something, a vibration in your hand, that we call it a trill, and it doesn't run by a motor or run by a battery. It's run by your heart. Okay, so it's all very natural. So don't get too worried about that I need a big surgery, I need something in order to prepare for my SS. That's very wrong. So these are the type. Of course, the first one, the temporary, we don't want that. Using catheter, stuck in your neck and start acute dialysis when you need it acutely when you're very ill. We only reserve that, when your fistula, your SS fail, you temporarily go on that, and we will recover the SS quickly so that you off the catheter as soon as possible. We pay more attention to the permanent type, the arterial venous fistula or arterial venous graft. So what are they? This fistula, the SS that we want our patient to have when they are at the chronic kidney disease stage 5. We prepare it almost like, when you have your creatinine around 400, 500, your eGFR drop to between 15 to 20, that's the time to prepare. Not like the one that Dr. Tan showed just now. When your eGFR drop to 5 mil, you need dialysis at that time. You can't wait for the 6 weeks or 8 weeks to get your fistula ready. So I'm going to go through this. What is AVF? AV fistula is actually something that our body doesn't like. The definition in our medical term is abnormal communication between artery and vein, created surgically for dialysis purpose. The abnormal term will tell you that the body actually doesn't like it. The vein doesn't like high pressure, doesn't like high flow, but this is the only way that we can make dialysis simple to us, because vein is just below the skin. You can stick your needle in easily. As long as you create a good inflow, good blood supply into your fistula, good outflow back to your heart, you get a good dialysis. It's very simple things. So the common site, you put in the forearm, we call it radiocephalic fistula. You put it in the elbow, we call it the brachiocephalic fistula. These are the two simple ones. You do it 45 minutes to 1 hour surgery, wait for 6 weeks, make sure you go on dialysis with it. Of course, if you don't have this straightforward vein, there are multiple, like this brachiobasilic, at least you need 2-stage surgery to bring it up before you can use it. So if you need to come to this, we are not talking about 6 to 8 weeks. We are talking about 4 to 5 months to get your fistula ready. So imagine the time that you suffer with something stick in your neck. I showed the picture to you what is a vascular catheter about. So how I do it, normally we map them. We are not like last time. We have a lot of surgeon last time. You just hold your hand up, tap. Okay, you got the vein, we go on surgery. Then when you ask about outcome, only 2 outcomes, success or failure. That's a dinosaur era. We are no longer there. Now we have a lot of diagnostic tools, a lot of machines that help us. You just go on the ultrasound machine, they tell you, yes, you have a good vein, you have a good artery on certain site, then you go on create it. So you avoid damaging unnecessary good vein, and you provide good outcome. Okay, if you go on this, I think your success rate will be about 90 to 95% in getting a fistula in a single surgery. You're not talking about, cut somewhere, wait for 2 months, sorry, folks, fail, you need another one, another 2 months. So you don't need that if you just get your hand scanned for site for fistula creation. We always do it in the OT. Those are micro instruments compared to last time, where our instrument is more fine and better. We have a more better magnifying loops. Our success rate is high. So the day that the doctor telling you it's only failure or success is gone. Most of the time we create it, we expect it to come out and should be able to use it by 6 to 8 weeks time. So this is how it looks like. If in the forearm, the vein and the artery, I just join it, end up, you just have an hour later, you just get a scar like this. Fistula will come up here. This is when you create in the elbow, the vein, the artery, you join it, this is the scar, this is how we join it. This is what I told you, only one string that I put in, nothing more than that. No pump, no artificial graft, no battery inside. It's very natural. So when to use it? We'll tell you when to use it. We have our own rules that you don't have to remember. Our rule of 6 weeks of maturation, 6 mm diameter, 6 mm deep, this all ours. We'll decide it for you. 6 weeks later, we'll do a scan, make sure it's okay. Like this is the one that I told you just now, the BBF2 stage. Take about 5 months to come up. And normally when you come out for assessment, I have a look in the flow, the diameter, and I decide, I will tell Dr. Tan Liping, right, this guy is ready. The flow rate in the fistula is how many 100 ml per, what size the needle you can go in, and we decide on the follow-up based on the vein and the fistula the patient have. So it's not something like, a car, you buy it, you use it forever. No, your fistula need to be serviced. Need to be serviced. At least if you have no problem, once a year, you go back for a scan, look for trouble. You don't want it to fail suddenly. This is what we face most of the time. During our clinic, one call in from the dialysis center. Doctor, please help. My patient failed the fistula. This morning I prick in, only clot come out. What to do? So when you further question, actually patients have some problems, some sign before on the dialysis machine, but fail to pick up. So the day that the fistula block, they get stressed. Where to get the fistula in again? Or if not, I need to get another vascular catheter stuck in my neck again. But of course, with technology nowadays, you don't have to do that. We can make the fistula flow back and function back on the same day, and next day you can go back for dialysis again. So these are important things, We provide information to patient once after fistula created, and we tell them how to maintain. We don't want a situation come out like this. A lot of center thought that this is normal. As long as you got something pop up, you can put a needle in, dialysis go on. For us, we just look at the picture like this. We know this fistula is not functioning well. Even though the center can tell me, we are dialyzing this patient for past 15 years. That means that past 15 years, patient wasn't get this good dialysis. Why this build up? Because outflow obstruction. Back pressure on the vein, causing the vein to dilate, become tortuous. Such patients' fistula will not function well. You can go on dialysis. But inflow, yes. Outflow back to the heart and to the systemic circulation is blocked. You'll never get a good dialysis. You can go on 4 hours. What you may get maybe the 2 hours effect. So this is what we do normally for follow-up. And you can see that the technology nowadays very good. Even up to a 0.1 or 0.1 mm we can detect it, but that's not our this one. It's just trying to tell you that we can detect things earlier before it fails. But what happened if you go to a doctor's? They tell you after scan, sorry, you have no vein, not suitable to create a fistula, but you still want to go on hemodialysis instead of peritoneal dialysis, or no chance for kidney transplant. So this is what I put in, an artificial graft, a soft plastic things, or somebody call it artificial blood vessel. We just connect, join it, if possible in the arm and the forearm. Just put it in and you can go on dialysis. Of course, this is not that good compared to your own fistula. Everything is your own spare part, your own vein. Even though they get injured, they recovered. Chances of infection is less. But when you put in this graft, infection is high, but at least you can go on dialysis rather than a catheter on your neck. This is how it looks like after you put in, about 2 hours of surgery. And 2 point, 1 inflow, 1 outflow. We get the graft in, and you can start dialysis. Some even the next day after the graft put in, but always I don't encourage that. What happened if you need dialysis? Let's say you turn very ill, you remake, you can't even take your normal meal, sitting there on a chair, you try to drop off, and you need dialysis. Doctor tell you, look at the urea, 40, creatinine, 1,700. You need dialysis, but you're not ready. So this is what you can get. we put in catheter. That's immediate access. We just poke on the neck or somewhere in the thigh, put the catheter in, we start dialysis for you. But this is the one that we don't want. We actually hate this a lot because this creates a lot of problem. We do it for acute dialysis, or sometimes when you need dialysis but your fistula is not matured, or something wrong with your fistula or your graft, you need it temporarily, so we put this in for a short period of time. And this is how it looks like. You know, this is calf one. It can last a bit longer, a few months. It tunnel and then go into blood vessel. This is directly coming up from your neck. Chances of infection is high. You're actually supposed to use it for less than 2 weeks. But in Malaysia, we use it for months. And some patients even come to me, I have that for 1.5 years. Wow, we can create a Guinness record in Malaysia by doing all these things. But this is what we face because patients don't get adequate information. They don't know that they are way out rather than just stuck to one, and then they just listen to the doctor who only know this. So we stick to this forever until they've heard somebody, okay, you know, my friend on dialysis on my next chair managed to get something done after a few months or things suffering. So they try to get it also. So you don't want this. This causes a lot of problem. What are the problem? Infection, the most common. And then Dr. Tan Liping will tell you, you know, the mortality for renal failure patient, 70% of them because of catheter-related infection. So you don't want that. The cost of treating infection is very high. Antibiotic for a few months, ICU, all those things. You don't want that. Catheter can be dislodged because it just stuck there with a few stitches. You can have blockage or clot inside. And worse is if you get this central vein occlusion. This is how it looks like on your hand when you have central vein occlusion. You have fistula in, vein here is blocked. Whatever blood flow into your hand cannot go out. Your hand blow up 2 to 3 times. Worse is, in a lot of states in Malaysia, the doctor doesn't know how to diagnose this. They tell a patient, nothing wrong, this is lymphedema. Yes, don't laugh, it's true things. I feel sad for the patient when they come to me. It's few years after it happened. And a lot of time you come early, we can recannulate, open up back the blocked vein, and we can have this settle. But they all come late. The success rate of reopen up a long blockage, central vein occlusion. I think you, maybe none of you know it, but it's very, very tough. Sometimes the intervention may take few hours just to open up that. But whereas if you come early stage, you may settle it in half an hour. So you don't have to suffer from that. So the information I want to pass to you is, don't wait until the stage that you need a catheter in your neck. It's not good. Prepare yourself. If you have a renal impairment, you come to the stage you need that. You get the fistula access in, whatever type of access in early. You start this smoothly. Not necessary that once you start with 3 times a week, right? Liping. And not necessary that you on that permanent on it. I have patients that on dialysis for 1 or 2 months, creatinine drop back to 300. They don't need it. 3 years after that, now still on my follow-up. She doesn't need that. So not necessarily that once you're on that, you're on that. You're on that for life. The other thing is that if you start your dialysis smoothly like that, prepare your access and get it on smoothly, you can avoid, staying in the ICU for weeks or months, recovering from a multi-organ damage. And things will go on more smoothly, and our experience with dialysis will be totally different. And having said all these things, there are certain patients will come with nothing. No vein, no central vein, all blocked off because of prolonged catheter insertion, all the vein exhausted, and still refuse to go for peritoneal dialysis, or had the infection before. That means they're out, totally no access. Still, we can go on other things. There are some complex fistula we can create it, build up the fistula, transpose the vein, and we still can do it. Or we go to the leg for access. Of course, not that good. Some patients just lost their leg, especially they are diabetic. And, when everything's occluded, we have something new. Previously, we gave up hope. This is, I'll show you a short video clip. some new access type that we actually don't need anything. We just need your heart and your artery. And we can go on create you an access that you can go on dialysis. You cannulate the access into your heart, creating the backflow. This is silicone catheter, wall strengthened by nitinol, a type of alloy. Make sure it doesn't collapse.
Venous outflow is cut away and the silicone rear end is discarded.
You tunnel it in your shoulder.
To the shoulder area incision. The arterial graft component is tunneled down the upper arm. Hero graft is connected and gently tucked into the soft tissue. The EPTFE graft is sewn to the inflow artery. Blood flows from the artery directly into the heart and bypasses stenosis.
There we are ready for that.
The hero graft is cannulated just like a conventional graft. Hero
This
graft
is
patients
how we
are identified
cannulate
in the
graft,
dialysis
or
center
cannulate
by
any
3 incision
fistula
sites.
instead.
Identify anastomosis.
This is what you face
connector.
when you go for dialysis.
A light tourniquet may be used to help locate the graft. Stay a minimum of 2 finger widths away from the arterial anastomosis.
You put a
Follow
needle in, that's
dialysis
for
unit
the
protocol
outflow.
for cannulation. Stay a minimum of 3 inches or 8 centimeters from the connector to avoid the graft beading.
So these are 2
Hero
needles you
graft
need
is
for
FDA
dialysis.
classified as a vascular
Whether
graft
graft or fistula.
prosthesis. However, unlike a conventional graft, Hero graft has no venous anastomosis.
Okay, we stop here. So the last video actually trying to show you that there's nothing that impossible nowadays. We can make things possible, and with technology and how vascular services progress in last 10-15 years, we can make things possible. It's just that we need to approach us earlier. We'll figure out how to settle your dialysis problem for you. Thank you for your attention.
Thank you very much, Dr. Tan. May we invite the 2 doctors up on stage, Dr. Tan. Ladies and gentlemen, we will now proceed to the Q&A session. If you have a question for our guest speakers, please raise your hands and my colleagues will pass you a mic. Please state your name and where you are from, and we'd like to encourage you to keep it to 1 question per person so we can get to as many people as possible. We'll now have the first question. Any questions?
Thanks for the opportunity to speak to you guys. My question, I have a problem because I was diagnosed with 3rd stage CKD. Now the only thing that seems to be wrong with me is creatinine level is high. I've got none of the other markers. I don't have, the fun breathing is not high, it's normal. There's no microalbuminuria. Don't have protein in the blood. Don't have red blood cells or white blood cells in the urine. So I'm not sure what's wrong.
Thank you. So the question is, some indeed have this particular presentation. They come, they see a doctor, and the doctor says, "Woo, your creatinine is a little bit high," and gosh, they give you a stage, which is really the most scary thing, because it sounds to a lot of people like cancer. Cancer, there's stage. So kidney disease now there's stage. So we give patients this stage, and all of a sudden our minds go crazy. I've got stage kidney disease. So a lot of our patients share similar worries. Especially creatinine slightly higher, and then they translate it into a kidney function, and there you get a stage. So what's wrong, or what has happened in the body to result in this kind of thing? So it's a little bit hard to say. I mean, when you come to see a kidney doctor, one of the things that we want to know is that we want to see whether or not this is something that can be reversible, meaning to say that the test that you have that shows your kidney functions a little bit less, is it because something is happening right now, or is it something that has happened way before? Okay, so that's what the doctor is going to be there to do. They're going to try to decide whether there's something that they can fix for you, or is it something that you have to live with, that you have to protect over the course of your life. So personally, some of the things that we do, like the urine protein, etc., tell us whether or not the kidney function that a person has will continue to drop or it will maintain. So there's a couple of questions. Number one, we want to know whether or not it will continue to drop, because then we tell you about how to protect your kidneys. The second is we want to make sure to tell you whether or not it will impact your life, right? So that's the other thing. So if your kidney function is just mildly impaired, surprisingly, it has no, most of the time, you don't know anything at all. It's silent, it's invisible. And its impact upon your life in terms of your health is also quite minimal. So it turns out your kidney function can drop from 90 to 60, yeah? When you have and when that drop happens, there's some things that change in your body. Your blood pressure may be a little bit higher, etc. But it doesn't really impact your life all that much. It's only when your kidney function drops to less than 30 that you start to get a lot of additional problems. So what has happened to you, perhaps, is that at some point in time, you may have had some injury when you were young, had some infection when you were young, etc., that has caused some injury pattern to develop in your kidney. And if that injury pattern happens a long time ago and doesn't continue to occur, and your kidney doesn't continue to undergo stress, and your kidney maintains its stability, then all essentially we would tell our patients to do is to keep on monitoring it in the hopes that it will not continue to decline, and to maintain its stability, and hopefully, it will never trouble you for the remainder of your life. And that's really one of the things that kidney doctors and doctors in general can help you, is that we are able to establish whether or not this pattern of injury is happening now, in which case we have to fix it, or is it happening before? And if it's happening before, what is the likelihood that the kidney function will continue to deteriorate, or is it going to be stable, or is it going to improve? And those are the complex things that we're able to help our patients achieve.
Thank you very much, Doctor. Can we have another question from the floor?
This question is to Dr. Tan. How do you actually reduce the creatinine level? Dr. Tan Li Peng, sorry. Dr. Tan Li Peng, how do you reduce the creatinine readings?
So creatinine is a marker. So this marker is actually from your muscle. Some people with a lot of muscle have naturally higher creatinines. Some people with less muscle have naturally lower creatinines. So if the question you are asking is the creatinine high because my kidney is not working correctly, and how do I fix my kidney so that it works better? So the answer would be, it depends on what's making your kidney not work, right? So if it's diabetes or high blood pressure that's making your kidney not work as well as it should, then really what you need to do, or what we need to do, is get your blood pressure fixed, get your diabetes fixed, and then your kidney will work better and the creatinine will come down, right? So if actually, for a lot of people, they've got really poor kidney function and the creatinine starts to increase, and one of the things they're doing is every day they're eating McDonald's, okay? They're having a nice hamburger meal, they're having a nice roast chicken, Hainanese chicken rice, etc. So what we know is that in order to protect a kidney function that's actually quite poor, one of the things that we can do is we can tell the patients, hey, don't eat so much, save the planet, eat less protein, okay? Eat less protein. So what that does is that causes less stress to the kidney, and when the kidney undergoes less stress, it functions better, and then the kidney function can increase because you're stressing out. Think about it like a factory, and then initially you have 100 workers, right? So now 50 workers go on strike, and you are left with 50 workers to do the job. The same job, production line still going. My God, your 50 workers are going to collapse, okay? So you say, let's cut down my production line. Let's drop my requirements. Then my 50 workers don't need to go OT. They have nicer sleep, nicer rest. They function better, right? So it's the same thing. So one of the things we do for our patients is that if we can ask them to reduce their protein intake, eat less, to stress out their kidneys less. And then for a lot of people, the kidney function actually improves. So the creatinine then drops. Yeah?
Thank you very much, Dr. Tan. Have the same question. Can we have another question from the floor, sir? So can we have your name as well as where you're from?
I'm Peter Chu. I'm from KL, Cheras. Doctor, I understand that the other organs like liver and all that, you have supplement in the market. What about the kidney? Are there any supplement to maintain or improve the kidney function?
Sure. So with supplements, we have to be a little bit careful, yeah, because we have to ask ourselves, what are we supplementing on? What are the benefits of these supplements? So as far as I'm gonna answer this in two parts. And for the blood vessel part, I'm gonna ask Dr. Kiao Tan to actually chime in because he's a blood vessel expert. Are there any supplements for the blood vessels? You know, because the kidney is a bag of blood vessels, yeah, amongst other things. So we want to hear about that. But for the kidney per se, it does a lot of different things for us. So when the kidney function fails or the kidney function worsens, one of the things that happens is that it doesn't process vitamin D that well. So vitamin D turns out to be a very, very powerful hormone within our body. It's everywhere. It's in our brain, it's in our blood vessels, in our cells. And plus, Malaysians, one of the sources of vitamin D is come from sunlight on the skin. And Malaysian ladies don't like sunlight and don't like to be exposed, to have exposed skin. So we naturally, as a population, have reduced vitamin D in our system. So you add that to kidney function, and a lot of the things that they lack is we lack vitamin D. So sometimes we will supplement vitamin D. You know, we will supplement vitamin D to restore it. The second thing is that with kidney function, that's slightly worse. It turns out that our body doesn't absorb iron that well. It impacts our iron absorption. So if you have a decreased amount of iron absorption and micronutrient absorption, usually that impacts immune function and impacts blood production. So we sometimes supplement that by asking people to take multivitamins which contain iron, maybe micronutrients like selenium, micronutrients like zinc, etc., things that are lacking because of the kidney dysfunction. If your kidney function is working perfectly, there's no need to supplement its perfect function. There's nothing we can do that can make our perfectly functioning kidney function any more perfectly than it can. And I think that's something that's really important about supplements. I mean, if our body is working fantastically, it's working fantastically. You know, God gave us some fantastic kidneys, and there's no way to make it better. I mean, we're just perfect. But if the kidney function is not so good, then we can supplement its function. For blood vessels, I don't know what the...
Before talking about the vascular health, I think a lot of you might under a friend's influence or something like that, they ask you, to improve further on your body function, be it vascular, kidney, liver, or anything. They ask you to try certain, traditional method. The last I heard was something sitting on an electric chair or something like that. I'm not too sure charging your kidney will help or not, but I know that definitely will cause some harm before your kidney function improve. In terms of vascular health, I'm trying to avoid that topic because it's a huge topic and by its own. Vascular health, just like any medical health, there's no 1 + 1 equal to 2 things in medical. Not like I do this, I get this. No such thing. So in vascular health also, there's no direct cause to the vascular disease or to the kidney disease, to the kidney supply. We are talking about factors, the causative factors which can affect the vascular health. Smoking, control diabetes, control hypertension, do more exercises. These are the things that we are talking about, the factors. Of course, if you have none of this, your kidney or your blood vessels still going down, then we blame the genetics. We blame other things, infection and things that can happen. So there's no 1 + 1 equal to 2 things here. In general, you need to take care of every factor to make sure that your medical or your vascular condition in a good standing to withstand any stress that come to challenge our life, something like infection, or trauma, or whatever, even mental stress sometimes, do give a problem in our vascular health. So get yourself ready to face all this challenge.
Yeah, but I like the question though, because it implies that we're thinking about protecting our body, and we're only given one body, isn't it? I mean, there's no other second body that we have. We only have this one body that we have. So I like this idea that people are thinking about protecting it. So I want you to be able to pass on this idea to your family members and friends and children, because especially nowadays with the children growing up, there's a lot of, a lot of things that our children are doing that may be impacting their bodies. So transmitting this, and the problem is that I think a lot of people start to realize that they need to protect their body a bit too late. About 50s and so on, 60s, they say, oh my gosh, time is catching up, I need to protect my body. So pass on that to your, to the younger people, and say, hey, protecting our body begins. It's even better if it begins when you're at a younger age. It helps a lot better. Yeah.
I think the best supplement at this point of time, the cheapest one is still adequate water intake. Do you agree that, Liping?
Oh yeah, that's what I'm drinking.
And the vascular disease, actually, when it started? 30 years old. It started very young, and then over years, 30, 40, 50, 60, 70. The older you are, the worse our blood vessel is. That's why most of us don't live beyond 80 or 90s. Because the body, the heart sometimes can take it, but the blood vessel can't take it. And why, you ask, years back, decades back, my parents' era, nobody talked about vascular disease. Why nowadays a lot of vascular disease? Because at that time, vascular health is not a problem. We are talking about, we are struggle to get good food, good environment, and good place to stay. And after that, after all the hard work, they don't live beyond 60. So you don't see that problem much. Nowadays, everybody live beyond 60, waiting for retirement. After that, enjoy their good life. But that's a time that whatever we earn earlier, you spend it on later, because the vascular health deteriorating. And that's a time that all the disease started. So prepare yourself since young. Not by 70, you start asking, shall I take this cholesterol medication? Shall I take that? Shall I go for supplement? Shall I take this herbs that people suggested? One more thing I'd like to remind you is that the herbs. I've seen a lot of renal failure patients after herb intake alone. So be very, very careful if you take herbs of unknown origin. Your friend might say good, may not be good for you, may not be good for everybody. So really want to get it, at least get it for Chinese insect or somebody, not from the roadside, somebody or your friend who's got a PhD by their own, trying to prescribe you something, and then once you go into renal failure, you can't sue them because you trust it by your own. So be very careful when you go on these traditional medicine things. Don't just say, oh, I saw it on the roadside, somebody sell it on the flea market. You start getting it and thinking that it will help you improve. We saw a lot. We saw a lot of these patients coming to us, come in straight from very healthy, straight into renal failure. There's no stage 1, 2, 3, 4, 5, nothing, straight into renal failure. So try to avoid those things that can harm yourself.
Question for Dr. Tan Li Peng. Dr. Tan, just now you mentioned about stone and cysts in the kidney. How does it affect kidney function? And also, if the stone and cysts are small, very small in size, can we just leave it untreated?
Yeah, it's a good question because a lot of people have the same problem. So the question is, how do kidney stones and how do kidney cysts affect kidney function? So stones shouldn't really be there. You shouldn't really have stones in your kidneys. That's not where a stone is supposed to be. So that's the first thing, yeah? So if you're able to have stones, nowadays we sort of classify people into people who can produce stones and people who can't produce stones, okay? So it's really interesting, you know. Last time people say, oh, it's because you, but actually now we divide them into stone formers and stone non-formers. So people who can form stones are special. So you're stone formers, okay? So stone formers, essentially, they can eat the same things and you can form a stone in your kidney. So when is a stone a problem? Stone is a problem when the stone becomes too big, and then they block the urine flow. Stone is a problem when they sort of pop out, and then they start to block the tubes, and then you have pain, okay? So that's when stone becomes a problem. So oftentimes though, if it's just a small stone like a grain of sand, it's hard to imagine how it would actually affect the kidney function. You've got 2 million nephrons in both of your kidneys. A little bit of a stone really doesn't impact much. But it's really not the little bit of a stone, isn't it? It's actually if the stone gets bigger and bigger, blocks it, gives you pain, gives you swelling, gives you infection, and so on. So that's when it becomes a problem. Cysts. So we have urologists who look at cysts. So cysts becomes a problem when the cyst becomes cancerous. Okay? So there's two kinds of problems. Number one, if cysts are cancerous, they are a problem. We need to get rid of it. Number two is that there are people with genetic abnormalities that cause them to be prone to make cysts in the kidney. We call this polycystic. Poly meaning a lot, cysts referring to these balls, right, of the kidney. So people have certain genetic tendencies to produce cysts. And if you are like that, these cysts will get bigger and bigger and bigger as you grow older. And one day, it may impact the kidney function because it's pushing the normal kidney tissue aside. And it's replacing more and more that normal tissue with this big ball of fluid. And that's how it leads to kidney function problems. But don't be alarmed, because many of you, if you go and do an ultrasound, will find a cyst. Okay? And lots of people have cysts. And this cyst can come and go. It doesn't imply that that cyst means you have a problem. It just means that what has happened to form the cyst is that the urine, as it's passing through these tubes, gets stuck. And then the urine makes this tube balloon, and it causes that cyst. For most of you, if you check it 1 year later, it will go away. Yeah? For most of you. But if you do have a cyst, make sure that you go and see a urologist, you go and see a doctor, you know, and get them to take care of you. Is there any...
I think those stone former, they have some metabolic abnormality in their body. So they form certain different type of stone form in the body. That type of, this one, most probably I think they will run in the family. Father have it, son will have it, the grandchildren will have it. So, you know, it's just the genetic coding decided the metabolism in our body. And that's why some people tend to get stone, somebody don't. But still, in general line, still drink more water works well.
Oh yeah. Drink more water.
That helps you to prevent stone formation. Yeah, it's true.
Yeah,
it's true. Yeah. You know, when you drink more, when stone forms more in your kidney, you flush it out. You know, some patient will come to see me. You know, I pee out a stone, pick out and show you. So yeah, that's right. So you drink more water, that actually avoid you know, the consequences or the complication caused by a stone.
If you do have a stone that you pass out, please keep it. No, not because of souvenir. Please keep it and give it to us. Give it to the lab. We want to analyze it. We want to know what's making up the stone. Yeah. We can analyze it in the lab, you know, and you can tell you why in the world are you, what's going to make your stone happen. Yeah.
I'm Mrs. Lim from KL. My son is 25 years old. He had a genetic PKD, like his father. My question is, how to prevent from further damage, and what are your advice on the portion of protein that he should take, and how much water he should drink a day? And second question is, he lately has a skin rash which is on his whole body, and he has some boils with pus and also itchiness. You think that, is it that because of he's having a type 2 diabetic? Is it related? because he has been eating McDonald's and soda drink every day, I think for about 8 months. Yeah.
Okay, the first thing you do is tell him not to eat fast food every day and not to drink soda. I mean, these are the things that we can control. There's a couple of questions. The first question was related to this genetic cystic disease. So these are very special group of patients. They are not the general population, so we don't see a lot of them. But in specific reference to your question, there are certain treatments that are sort of postulated to be now available to help with these sorts of problems. So it's a good idea to see a kidney doctor because I think it's quite detailed. And the second issue is, if you have an itch, is that implicative of kidney problems? Is it implicative of diabetes? For most of us, no, because how many of us have itch? A lot of us have itch many times. So it doesn't mean that if you have an itch, you are diabetic, or if you have an itch, you have a kidney failure. But some kidney failures have itch. Yeah. So they don't always correspond to each other. How can you tell? Go check. So the only way you can check, like most of these things, is you need to go get a test, check your blood sugar, check your kidney, get your creatinine, check your urine, and then you'll know. Because there's no way to tell. I mean, an itch could be just a mosquito bite. It could be an allergy to something in the environment. It could be eating too much McDonald's, or it could be kidney, or it could be diabetes. We can't tell. So the only way to tell is to check. Yeah. More checking is better than more checking is better than less checking. That's in general my rule of thumb.
I think the other side you're looking at that is if you have polycystic kidney disease, and your renal function is normal. So we don't correlate the skin itchiness to the renal disease. It could be a separate condition, eczema, dermatitis, contact dermatitis, or whatever situation, insect bite or anything in Malaysia. So you need to know the kidney function. You need to know your blood sugar level, and to rule out that it's not diabetes. Because nowadays things are very possible to anybody. And last time we used to say that you have a heart attack at 50, 60 years old. Now even we have a friend die at 30s because of heart attack. So things can happen because we live quite differently from last time, and we don't take care. We just want to enjoy. So we suffer from it also. So the best way to know better is if he has such problem, so he need regular checkup, maybe yearly, annually, just check up. And then better control on his food intake, because that he is susceptible for problem. So you don't want problem to come earlier. So the only way is to control. Train him during young, rather than reach a stage that you can't control him anymore, like us. Then you can't control. You face a problem at the late stage.
Just a quick word to address just now. I just forgot there are two other sub questions there. One is protein intake. So WHO now tells us how much protein we should take. Yeah. So we should take 0.8 grams per kilo per day for a normal average person. So you can go and calculate that. So 0.8 grams per kilo per day of protein is WHO's guideline to everyone in general. If you have kidney disease, you are expected to eat less, 0.6 grams per kilo per day, because it reduces your stress on your kidneys. So how much is that? One matchbox size of protein, which is about one matchbox size of chicken or fish and so on, per day.
Disappointed Malaysian. Sorry.
It saves the environment, by the way. So the other thing is water intake. Yeah? There was a sub-question there, how much water should we drink? You should drink as much as your body needs. Your body will tell you. If your body is working correctly, it will tell you. In an aircon room, you don't need to drink that much. You're not sweating, you're not doing this. How can you tell? One of the easy ways, look at your urine. If your urine is quite clear, you're drinking enough water. If it's yellow, you're not drinking enough water. Specifically for cystic kidney disease, there have been studies that show that the more water, the better. So, usually we ask our patients to drink more than 2 liters of water a day. But it's quite specific, and you should get detailed information from your kidney doctor.
Thank you, doctor. My name is Thananayagam. I'm from PJ. I am a diabetic from 1986. And 3 years ago, 30 years after being diabetic, my endocrinologist told me, he says, I want to do a scan on your liver because I've been on oral medication. And he says, okay, fair enough. Did a scan at University Hospital. Instead of finding the liver was okay, but they found a massive right renal growth, something that had come out of my kidney and had grown to be 12 cm by 10 cm by 12 cm, big. And when I went and saw my endocrinologist with the report, he got worried. He referred me to a urologist. And the urologist did a CT scan. And it was confirmed there was a growth coming out of the kidney. And they had to do a surgery. Discovered it was stage 2 cancer. So I'm now in one kidney. And of course, with all the medication, things like that. So this morning when I came for the test here, they said my CRE was 26.5. My ALB was 10 milligrams. So I just want to know, how am I doing?
So how many of you got the urine test this morning? All, So there's about 100 people, I think, with 100 tests. So about 12% of, 10 to 12% of people will have an abnormal test, and that's just population spread. So what do these abnormal tests look for? They want to look for protein leakage in the urine and tell us about how the structure of your kidney is doing. So if you're getting an abnormal test, number one, it may mean that your kidney structure is a little bit leaky, okay? So that leakiness can be mild, can be moderate, can be severe. So if it's slightly higher, and it sounds yours is slightly higher, so the first thing to do is to make sure you put a little less stress on your kidneys. So for those of you who have a little bit of that protein leakage in the urine, go and see your doctor. I think it's important to find out, to quantify, and to reproduce it, because you don't want to just trust one test. You need to do it a second time, confirm it, and after it's confirmed, then your doctor should be able to tailor some advice to you to try and reduce that burden load on your kidneys. Yeah, I think that's the...
We have 15 minutes left, so time for a few more questions. Does anyone have?
Thank you, Doctor. I think I belong to those categories that are stone formers. I wish I can form gold.
We all wish.
2 years ago, I felt a severe pain in my groin area, and then it was discovered that there was a stone in my urinary tract. The doctors tried blasting it out, but I don't know whether it has been removed, but the 2 years has gone by and it has caused me no pain. And only 2 weeks back, I went for a thorough medical checkup, and it was discovered there's a stone in my gallbladder. So do you think I should let it stay as it is until it causes me pain, or I should getting it removed? Because some people, they even remove the whole gallbladder. The second question is, why is it that stone only occurs in kidneys, urinary tract, and in gallbladder, but not in other organs like liver or pancreas? Thank you.
It's more of a surgical question. Is your cholesterol level normal? Yep. The stone in the gallbladder and stone in the kidneys are different pathology. The stone in the gallbladder, they can be a pigment stone or cholesterol stone. Most of the time, cholesterol stone. So what you need is just a stasis of your bowel in the gallbladder. They can form stone inside, especially if some infection go in. The treatment actually depend on the symptom and the size of the stone. If they are small, a lot of time they come out. When they come out, you know it, because you experience severe type of spasmodic pain. Come, go, last a few hours. After that, your face turn from red to green to back to red again. Settle, the stone is out. But if the stone size grow bigger, 1 cm above, don't expect it to come out. And those type of situation, what you can do is either you remove it quickly, or you wait until you go into trouble. trouble like they block the gallbladder, and then or if they block the bile duct, then you have a jaundice, the face turn from red to yellow that time, and the yellow will never come down. Then you need to surgically remove the stone and gallbladder. So it's up to your choice. We never force you. It depends on the size of the stone, depend on the situation. The surgeon should advise you separately, whether which one is good for you. If it's still small, 2 mm, 5 mm, maybe you can still wait. Just reduce some of the oily food, and the stone sometimes disappear.
Let me address the reason, or the question, why are you able to get stones in the kidney and why it's not in the pancreas and so on. So the kidney is a special place. It is our body's main mechanism to control chemicals, or what we call them electrolytes, in the body. So electrolytes are specific things that the body needs to control in a very, very tight range. And these things are calcium, magnesium, potassium, sodium, chloride, bicarb, etc. So all these things get filtered through the kidney. It passes through the kidney, comes out in tubes, right? And if you think about the kidney, you can think of it like a chemistry lab. So everything, all these concentrations of these ions are being micromanaged by the kidney. And any deviation in its micromanagement causes a change in concentration. So if you like chemistry, right, and if you have a little chemistry, if you remember your chemistry classes, you change alteration of concentrations, you get different reactions, okay? So the same thing is happening in the kidney. So the kidney is a chemistry lab, right? So some people who are stone formers have a different chemistry lab and different environments in that chemistry lab in your body. So what's happening in the kidney is all these chemicals are there, and then the environment of that particular person changes, and these chemicals interact, and they form different structures. And one of those structures is a stone. So the stone is made out of a combination of calcium and oxalate, or calcium and phosphate, or calcium, magnesium, and oxalate. So these three ingredients come together in the right setting, and they form crystals, and these crystals have to meet each other in the right setting, and then they glue together and they form a stone. That's why we say some people are stone formers and some people are not stone formers, because some people, no matter how, they can't get stone, and some people, no matter what they do, they get stone, So something's different in the chemistry lab in the body, which is the kidney, right, that controls these things. That's why they are able to form stones. Why can't you get it in the pancreas? Because the pancreas is not involved in these chemicals. It's not the chemistry lab of the body. It is the insulin-producing lab of the body. That's why you have these problems. Why is it in the gallbladder? Because the gallbladder is where they keep the bile, or the bile which is concentrated enough to use when you are eating, fats and proteins and so on. That's why there's intermingling of these, and in the correct saturation point, they form a solid. And that solid, it becomes a stone. So it's very interesting. So if you get a stone, keep it, because we want to analyze it.
And anyway, if it is cholesterol stone, it looks yellow. Something like gold that you want, you wish.
Doctor, this is a general question. With the current outbreak of H1N1, how can it affect our kidney functions?
We don't like H1N1, first of all. So this is a general public announcement. Go get vaccinated. There's you have it at Ara Damansara. So nowadays, a lot of attention is being paid to vaccines and so on. So influenza being one of them. So how can it affect our kidney function? The kidneys, in general, are your body's filter mechanism. You can have a mild influenza infection. You can have a moderate influenza infection. You can have a life-threatening influenza infection. If you have a life-threatening influenza infection, these patients end up in the ICU. And if you end up in the ICU and you're sick and you're dehydrated and your blood pressure is no good and you get a bacterial infection, get pneumonia, your blood vessels are shot, your kidney is gonna suffer as well. So that's how all things work. It not necessarily need to be H1N1. Any kind of infection, any kind.
There's no direct link. It's just that when it turns your body too ill, then it affect. Otherwise, there's no like I say 1 + 1 = 2 things.
Dengue, same thing. Yeah.
Okay, thank you very much, Doctor. That's all the time that we have today. Thank you, Dr. Tan Lee Peng, Dr. Tan Kia Ling, for attending to our audience's questions. And with that, ladies and gentlemen, we have come to the end of today's StarLIVE session. Once again, a big thank you and a round of applause for our Ladies and gentlemen, thank you for being part of this morning's event. We hope to see you in the next StarLIVE session. Don't forget to pass us your feedback forms as you exit, and have a great day.